So we have had a few abstract presentations, and for the next half an hour, I have been entrusted the job of trying to talk about how we are going to give adjuvant or neoadjuvant treatment of what is potentially resectable EGFR mutated non-small cell lung cancer. Okay. These are my esteemed panelists, all on stage, and again, I've listed them alphabetically by surname. There is no bias. Okay. What is the most important question for this panel? Panelists or anybody? Just a guess. No? No, something more.
First generation TK where we can use.
No. One last guess, anybody? No. All panelists are from the same discipline in this era of multidisciplinary management. Everybody is a medical oncologist. And so the important question is, would we have some, perhaps significant differences of opinion, or it's going to be consensus as the norm rather than the exception? All right. The first trial, this was the Korean trial, an abstract. Salient features were drug developed and used currently in China, only included stage 1B patients, typically who have no indication for chemo, impressive hazard ratio of 0.2, 3-year DFS rates 95% versus 87%. DFS benefit was there, but OS data is immature, and the number of events were in general very low, 13 totally, 2 with the icotinib and 11 in observation. This was the other trial, again, a drug developed and used currently only in China. It's a third generation as opposed to the other one, which was a first generation. Study included stage 1 to 3 patients. There was no data if eligible patients received chemotherapy. Single arm, no comparator, small study, 66 patients, retrospective. A 1-year DFS rate which cannot be beaten, 100%. And the DFS and OS data are both immature. This was the updated OS from event study. The salient features again, 3A, erlotinib duration 2 years. The comparator was vinorelbine cisplatin, and I'm always have the query whether it is justified as the standard of care in this current era of better tolerated and equally effective chemotherapy drugs. I can understand from the point of design, but if you talk of real world setting, do we really want to use vinorelbine cisplatin as our comparator? The DFS benefit was lost with time. So at 2 years, it was 81% versus 45%. At 5 years, it was 48% versus listed as not accessible. I really didn't understand what. And the overall survival was positive, 5-year survival 85% versus 51%, favoring the TKI arm with a hazard ratio of 0.32. This was in JCO earlier this year. The other one was in JCO last year, which was the IMPACT trial using gefitinib. Again, stages included were 2 to 3. Gefitinib duration 2 years. Same issue, in my opinion, with the comparator arm, which was vinorelbine cisplatin. DFS was 36 months versus 25 months. And the OS was 5 years, 78%, 75%. It was listed as excuse me, it was listed as favoring the TKI arm, but the DFS benefit was lost with time and there was no OS benefit. So before we go over to a panel, let's start with some real world experience. This was Mrs. LS, a 52 years old lady with no smoking history, resident of Punjab, presented to us with cough for 6 months, hemoptysis for 2 months, and hoarseness of voice. A CT thorax showed a 4.5 into 4.0 centimeter left upper lobe mass, closely abutting the mediastinum. Bronchoscopy showed a left vocal cord palsy, the left upper lobe bronchus completely occluded with the polypoidal growth, and an endobronchial biopsy, adenocarcinoma NOS. So PET CT was done, which showed an FDG AVID 10.5 SUV, 6 into 5.8 into 5 left upper lobe spiculated mass abutting the mediastinal pleura, extending into left hilum, with ill-defined interface with the left pulmonary artery. Clinical stage T4N1M03A PS0 and neoadjuvant chemo, pemetrexed and cisplatin started. Reflex molecular testing happens at our center. It happens probably in TMH and other centers, and then EGFR exon 19 deletion mutation was detective. The others initial testing were negative, and so C2 was, for C2, gefapixant was added to chemotherapy, thanks to the trial by Vinita, Vijay, Dr. Kumar, and everybody else. I know it is in the metastatic setting, but we'll discuss that later. A surgical opinion was sought after the second cycle, and it was they said to give 3 more cycles and then reassess. So she tolerated it very well. Dose intensity delivered was approximately 95%, and the notable toxicities were grade 2 fatigue and anorexia. A repeat PET-CT after C5 showed the FDG avidity was 7. The size was down to 3.5 by 3 into 2.4, but it was still abutting the mediastinum, extending into the left hilum, and there was still an ill-defined interface with the left pulmonary artery. It qualified as both metabolic and radiological partial response, with the RECIST down to 42% and WHO 70%. And so the plan was that if an R0, R1 resection was feasible, to do surgical resection, otherwise to shift to concurrent chemoradiation. And the patient underwent a thoracotomy and a left upper lobectomy with a sleeve resection of the left pulmonary artery, along with a systematic lymph node dissection. And the final stage was G2A CNR predominant invasive adenocarcinoma, YPT2AN0, which is 1B, based on a size of 3.5 by 3.2. All removed 8 lymph nodes were negative. It was R0, L0, V0, which means no lymphatic or vascular invasion, PL0, no pleural invasion, STAS negative. Residual tumor was more than 10%, and adjuvant osimertinib was initiated. Now, for the next 25 minutes or so, we are going to ask our panelists what is their preference, which drug, monotherapy or combination, which disease or patient characteristics define eligibility, for how long, what are the criteria for stopping treatment, what are the preferred endpoints of efficacy, what is the magnitude of outcomes that would make adjuvant TKI as the preferred treatment. And so just to start, this is a summary of the 4 large trials, EVAN, IMPACT, Adjuvant, and ADAURA. EVAN was the only phase 2, the other was all phase 3. And that's why the patient numbers were just around 100 in EVAN. IMPACT and Adjuvant had around 230 each or 220. ADAURA was the largest. Stages, EVAN was restricted to 3A. IMPACT was 2 to 3. Adjuvant was 2 to 3A. And ADAURA was the most wide, 1B to 3A. Now, the comparison here is in the first 3, it was basically the first generation TKI versus vinorelbine cisplatin. In ADAURA, it was osimertinib versus placebo. The duration of treatment was 2 years for the first 3, which were the first generation TKIs, and it is 3 years for ADAURA. And if you look at the DFS benefit, it was positive for EVAN. The OS benefit was also there. For IMPACT and Adjuvant, there was neither a DFS benefit nor an OS benefit. And in fact, you can look at the 5-year DFS rate was identical in Adjuvant, 23%. And in fact, in IMPACT, it was 34% versus 32%. Now, ADAURA, obviously, you've heard it since morning, a very impressive hazard ratios, and OS data is still immature. And importantly, the hazard ratio is there in all stages. So before we start, do you know when you were born? I know it's a very, very stupid question, right? But there is a reason. And this is how it is defined. The greatest generation, the silent generation, baby boomers, generation X, millennials, generation Z, and generation Alpha. Now, we are going to talk about this a little bit in the drugs. I am generation X, my children are generation Z, and so there are people who might be millennials here. So when we talk of all of these generations, adjuvant TKI for resected EGFR mutated, which drug? You have first, second, third generation which are available. You have the generation X, and you have generation Z, which are drugs not available here. I mean, example, the first 2 drugs. So we can start with Vasu.
I prefer third generation TK osimertinib.
So that's it. You have no other preference, right?
Yeah.
Sure. Kunal?
Yes, sir, I would agree. I will prefer the third generation osimertinib.
2 out of 2 osimertinib. All right. Uh, Vijay?
I would prefer third generation TKI, that is osimertinib.
Okay. Ajay?
Sir, I would prefer third generation, but in this scenario, he's already taken gefitinib and shown good response. So I think
Who's taken?
in this case which you have presented,
No.
he
This
was
is
added.
general panel
In general,
discussion.
sir, I will prefer third generation.
All right. Mansi?
Okay, so I already discussed this in my, so it's definitely osimertinib out of all of them right now. We wait for further data. With osimertinib, there are caveats. I think we'll be discussing them in detail. So just with a one-word answer out of the three, awesome.
And the senior most, ma'am.
No, I agree with Mansi. I mean, the approval is for osimertinib. We don't have overall survival data, so it has to be a shared decision. If we had aumolertinib, then that might be an option. Erlotinib has positive, the only drug here that has OS data is erlotinib, but that was only 3A, like a lot of caveats to that. So, I don't know. Yeah, in short, I don't know the answer.
So there was also a select trial which was a single arm trial done in US in which they gave people, had surgical resection, received standard of care which was adjuvant chemo and then gave erlotinib, and that also was in a way a positive trial. So
So I think both select as well as impact, right? Evan, they were both phase 2 though. Even select was
phase 2.
So I don't know the answer to that, but something. I mean, we can't sit here and say osimertinib for everybody and then nobody can afford it. So I'm not
One other important aspect was that when the Radiant trial was designed, the EGFR mutation concept had not come in. And therefore, it was designed for testing efficacy of erlotinib for EGFR amplification by FISH. It was modified during the trial to have a subgroup based on mutation analysis, because that's the time the mutation data came in. And because it was a subgroup analysis, even though it was positive, it did not meet the trial criteria for a positive trial. However, if you looked at the Radiant trial subgroup for mutation analysis, there was an OS benefit, even though the Radiant trial overall was not positive. So as of now, I think the only other drug which has shown OS benefit, be it phase 2 studies, be it the subgroup analysis of a phase 3, is erlotinib. Next question would be that if your first generation drugs don't work, you have data which has come in from TMH and Japan that you combine gefitinib with chemotherapy, you have data on combining erlotinib with VEGF inhibitors. Would you be tempted to do any of that in the adjuvant setting? Let's assume patient cannot afford osimertinib and all of the other generation, next generation, nothing is available. You are left with erlotinib, gefitinib, maybe afatinib, all of which are generics. And you have concerns that this may not be as effective as you would want it to be. Would you be tempted to do this? You can choose any order in which to answer, or anybody who wants to take it.
So pending further data, not really. It's very difficult to actually get convinced about, and convince patients about osimertinib right now. Would wait for further data, would probably, so the good thing is that trials are coming up. So would also offer patients opportunities if there's any trial happening pan-India to go into a trial setting so that, maybe we can find out what is going to happen with combination.
Agreed. If trials are happening, suppose there's no trial available, and the patient says, I don't care if there is evidence or not. I would just like to be given the most effective treatment in your opinion, and I'm okay with that.
So right now, sir, as we are aware for chemotherapy in adjuvant setting, in patients who are high risk 3A or 2, where there is a macro benefit with chemotherapy is proven. So chemotherapy will be by default will be my choice. In addition, if EGFR comes positive, then osimertinib is not favorable, then definitely I will prefer to give combination of chemotherapy followed by adjuvant TKI.
Sorry, am I allowed to ask a question? So, asking to Ajay and
Sure,
you,
sure, sure,
Navneet.
sure.
So, I think, so your statement was that you would always give chemotherapy. So, in ADAURA, there didn't seem to be much of a difference in the hazard ratios, whether they got or not. But so, would you, that is, so if the patient can afford osimertinib and will be taking osimertinib, you will always give chemotherapy?
So to help you understand
Maybe still I consider because there is a proven benefit with the chemotherapy in terms of OS benefit. So even looking at the ADAURA data where we have not seen, means they have shown key patient irrespective of chemotherapy, there was benefit in both the groups. But data is still mature for OS, so I think still I'll consider to give combination with chemotherapy and followed by osimertinib.
You know, I totally agree. No, and I think that's the bottom line. We have the chemotherapy adds life to the patient. It's just that there has been a lot of discussion over that globally. That since it didn't seem like that the patients had more benefit who got chemotherapy in ADAURA and then osimertinib and then only osimertinib, right? What are your thoughts on that?
No. So just for the benefit of everybody. So the analysis from the ADAURA published in Journal of Thoracic Oncology very recently regarding this specific issue, chemo or no chemo, 60% got chemo. This was very highly skewed towards 2 and 3A, in which 75% got chemo, and stage 1B, only 25% got chemo. Their analysis shows that the hazard ratios are still favoring adjuvant chemo, but I think the fundamental difference remains. Chemotherapy are by definition cytotoxic, and targeted therapies as of now are by definition cytostatic. And so when you are attempting a cure, which means a curative intent treatment, whether it's adjuvant, neoadjuvant, whatever you're doing, you are trying to make sure that whatever your aim is going to work. And I think for that, chemotherapy still needs to be the backbone, the cornerstone. The only questions which come up are that once you have done that and you are going to give adjuvant, then you have to factor in everything, the cost, availability, treatment duration. That's what we are discussing. So as of now, you are all correct. There is no data that you could combine erlotinib and bevacizumab or ramucirumab in the adjuvant setting vis-a-vis the metastatic setting. Similarly for PEM-carbo, are you people doing something like that? No? You should.
That 60.
No, I meant a trial only. So,
Sir, that 60% of patients who received chemotherapy in ADAURA, they are both in placebo and osimertinib. Both arms there.
Overall 60% received.
That's what.
75% 2 and 3, 25% in 1.
Means roughly 30% in observation and 30% in the osimertinib.
No. You have a pool of patients, the study population.
This side 60% and this side 60%.
So
Means osimertinib is not an alternative to the chemotherapy.
I am not saying that. If you ask Astra,
In the trial also, nowhere told that osimertinib is giving benefit to EGF for positive patients, irrespective whether they received chemotherapy or not. But osimertinib is not an alternative to the chemotherapy. Am I correct?
You are correct. As of now, most of us will believe osimertinib is not an alternative to
the
chemotherapy. It is after people have been given chemotherapy, or you have groups of patients who are not eligible for chemotherapy. But if you ask this question to Astra, they might have different views on that. Or if you ask for people who have spoken for Astra, they might have different views on that.
No, just add a point. See, when you have a trial running at your center and you're not able to give chemo for whatever reason, patient is unfit, had surgical complication, you can randomize those patients. But in real life, if you have a fit patient, there's no reason why you should not give him chemotherapy, right? And on the other hand, when you look at forest plots, when you look at the delta, all it tells you is it works even in patients who did not get chemotherapy, right? There could be a stage 3 patient who did not get chemotherapy. Obviously, the osimertinib will work there. But you can't compare osimertinib with chemotherapy based on the forest plot of ADAURA.
If patient is fit and patient is affordable osimertinib, then he should receive chemotherapy and then he has to receive osimertinib. That's what I mean.
If he is 2 and 3.
2 and 3.
Not if he is 1B.
So, critics or discussants have also said that, and I also agree with that, that we have OS data for adjuvant chemotherapy. We don't have the OS data for osimertinib anyways right now. So probably long-term follow-up once, maybe 2 years later.
Go ahead. 2 years later, who knows what's happening? Let's discuss what's now. All right. So let's move ahead in the. Can you have a timer somewhere so that I know? 9:48 means 9:48 left or done? Okay. So, okay. So which disease or patient characterized define eligibility? And I think we have whole ranges for what is resectable 1 to 3Bs, which is T3N2, T4N2. Would you want a clinical stage or a pathological stage? Types of mutations, all of this data is going to be restricted to exon 19 deletions and L858Rs. What do you do if you have L861Q, G719X, S768I, for which you all know which the best drug is, exon 20 insertions. You have dual mutations, including de novo T790Ms. And so, what are your thoughts about this? Anybody? You can start from one end and come to the other end.
So for from stage 1B to 3A, we preferred for adjuvant osimertinib.
That's okay. What stage would you take? Clinical stage versus pathological stage. Suppose the clinical stage was CT3N2 and the pathological stage was PT2N0. What are you going to take for deciding treatment?
So I'll take the clinical stage.
So that is dependent upon whether patient received neoadjuvant treatment or no.
Yes, sir. That will if the patient has received neoadjuvant treatment and it has downgraded to a lesser stage, then we'll prefer the clinical stage for deciding adjuvant.
And suppose patient has not received neoadjuvant therapy, then which stage will you take?
Then probably pathological stage.
Correct, because the clinical stage may not have been accurate if no neoadjuvant treatment was given, and a pathological stage is likely to be the most accurate because the disease characteristics are deemed to have not changed pre and post operative without any therapy. Okay, and you had an uncommon mutation, what do you do? There is no data. Osimertinib is not going to work for any all of exon 20 insertion. What are you going to do? And you have that report in a patient who is undergone surgical resection.
In such setting, I would like to observe.
Okay.
Me also, if in uncommon mutation, definitely there is lack of data, so I prefer to observe. Means chemotherapy, if fit and followed by observation.
Same with others. I will prefer 1B to 3A, and if neoadjuvant, I will take clinical stage. If upfront surgical, then I will take pathological stage. And uncommon, I will like to observe.
Okay.
Yeah, I will prefer to go ahead with stage 1B to stage 3A. And for surgical patients, I will prefer pathological stage. For uncommon mutations, so chemotherapy would be the preferred choice. And yeah.
So nobody is tempted to use a afatinib for this L861Q, G719X?
Not
No.
urgent, yeah.
Okay. Mansi.
So I'll start from the bottom. So type of mutation as of now, no. Pending further data, or I mean, if somebody like you said, patient is really insisting, then maybe discuss with the patient that we don't have any data, right? But no. In terms of staging, of course, would prefer pathological staging. I would like to add that Adora didn't really do a very, good pathological staging. Neither did they, look at the CNS very nicely. So I really don't know how that will, in the context of it in terms of today's discussion, but I would definitely want to stage properly. Disease stage, 1A, no, 1B, very select patients. Again, it's going to be a personalized decision with the patient, sitting down, maybe a tumor board, looking at a lot of factors. 2, 3A, yes, 3B, I am not sure.
So, ma'am,
Final.
I have a question in 1B, which select patient?
So we know there are certain subsets of patients that don't do very well. So, okay, so let me start by saying that the 1B data, you know, what is happening is even with that other study of 1B with the first generation EGFR TKI, is that we don't know whether how many of these patients are actually just getting cured. Right, so we need longer follow-up, at least that's what I feel. We need longer follow-up when it comes to 1B for adjuvant osimertinib or adjuvant TKI2, because we'll end up giving 3 years of a very expensive, a little toxic therapy to a patient who may already be very well cured without it. So I am not sure about 1B as of now. This is a discussion which has to be taken, you know, in decision with the decision has to be taken with the patient. This is the data, we don't know. Seems to be working very, very well as of the data right now, and leave it up to them. With regard to high-risk features,
Which are the high-risk features?
yeah, so I'll just tell you. With regard to the high-risk features, so that helps us in telling our patients, or, you know, patients also will ask us the same question. So if there is a vascular invasion, I think there was a study which was discussed in the previous panel. If there is a poorly differentiated carcinoma, the usual guidelines. That's what I would say.
So typically that is called optional pathological descriptors, and they include pleural invasion, perineural invasion, lymphatic, vascular, the completeness of resection R0, R1, R2, STAS, and there are other things which are coming on. Final word, ma'am.
So I agree with all of this. I have a question actually to you and to the panel. So exon 20 insertion, clearly we would not give EGFR TKI. Would you, and all of you said observation, would you consider adjuvant Atezo? Would you consider it for, as per IM power 010, Navneet or any of the panel?
So the first two, no. I would.
Uncommon, no. Common, no.
No, uncommon, no. So Empower 010, I will not give to anybody with the uncommon. Exon 20 insertion, my personal preference, completely off-label with zero evidence, is that if I had access to amivantamab, I would use that and not use atezolizumab. But that is my personal zero-level evidence opinion, because I do not know. All of this is driven by the fact that when you have a targetable oncogene driver alteration, it is the driver alteration which drives the tumor, vis-a-vis immunotherapy, which is based upon a composite of sort of tumor burden, not exactly a TMB, but a tumor burden. And therefore, that is the whole reason why monoimmunotherapy never works for these oncogenic driver alterations. Exon 20 insertion is probably sitting somewhere in between. I don't really know where it would get classified, but I would be very hesitant to give atezolizumab monotherapy for this.
So, amivantamab dur ki baat hai.
Chalo,
So if you had ALK, you would give adjuvant ALK inhibitor? I think what you're saying is that you would, in the molecule.
I have no evidence for that. It is completely personal. I would be tempted to, just by a lot of things which we do are extrapolation of data. There is no evidence for that. I mean, you have 10 people with evidence and I would be the only one standing out. But sometimes whatever inference you can draw or logical from the trials on the basis of biological plausibility may need to be extrapolated. So yes, if it is an ALK positive, I may be tempted to give it. But again, that may be just me.
Sir, but in clinic now, suppose these common mutations are negative and some uncommon mutations are seen. And if you go by the IM power 010, so their exclusion criteria is only the ALK and EGFR targetable. So I think if you are following some study, so we should stick to the guideline by the inclusion exclusion criteria.
Correct. So
in general, we know that EGFR mutation or ALK mutation patients will not respond to immunotherapy.
Wasn't this
in
30
our
minutes?
practice, we have seen there are odd patients who are on EGFR positive and 2 years on immunotherapy.
So guidelines are to guide you. How you interpret them is your decision. I am saying this while being chair of ASCO guidelines, so I'm like contradicting myself. But guidelines are only meant to guide you.
Because sometimes, sir, I've seen member of parliament has come and he has every resources, and he was uncommon mutation positive. He asked me to give the best therapy in the world.
So uncommon mutation, EGFR, one of those, I would put that person, parliamentarian or no parliamentarian, on afatinib and not on immunotherapy. All right, so I think we'll have to wind up. Duration, nobody knows the answer, right? It's all your choice, 2 years, 3 years, 5 years, disease relapse, unacceptable toxicity, endpoints. Everybody wants OS benefit, right? But we don't have OS data yet except for erlotinib. Everybody's going to wait for ADAURA. That is going to be maybe 2-3 years, whatever, and maybe longer. But there are other things, DFS benefit without worsening, DFS benefit without grade 3 AEs, or OS benefit even if there is associated worsening or no improvement QLs. They're all things which we should ponder. Magnitude of benefit desired, it is highly, highly subjective. Whether you want a 5%, a 10%, a 15%. Remember, LACE analysis was 5% at 5 years with adjuvant chemotherapy, right? Or if you have DFS sustained for 4 years, people say, oh, okay, that's good enough for me that I am without disease for 4 years and I can do a lot of things. Remember, we still treat metastatic NSCLC even though there may not be an OS benefit, simply because you can get a PFS benefit with an improvement in QOL life, and it allows patients to do a lot of things which they otherwise may not be able to do. All right, finally, last thought, what exactly is resectable? We had this in the first session. So we believe it is no evidence of intrathoracic metastasis or intrathoracic entry disease has been ruled out. N2 is not bulky or multi-station, and a primary lesion is amenable to R0. But we recently had cutting short instantly detected chest nodule on radiograph while doing pre-op evaluation. This was the lesion. There were PET showed lesions in adrenals, vertebra, and it was a lipidic adeno. And the dilemma was whether it was 4B or not. And so the plan was that because the primary lesion was resectable, we would do a PET-guided biopsy from the adrenal and vertebral lesions, and if that was all negative, do a staging EBUS, rule out N3, then surgical resection. Now this patient took second opinions, and by second opinions I mean this patient had 2 practicing oncologists in the US with continuous feeds coming to me and the patient to do a lot of things. And so an MRI brain and spine was done, which was negative, and an abdomen was done, showed both adrenal glands, so chemo was started. And then another PET was done too early, I don't know why, and it was deemed to be not technically feasible to biopsy them. An exon 19 deletion was picked up, and since it was inability to exclude metastatic disease, we changed to the TMH regimen. After C3 and 2 cycles of the doublet, there was grade 2 mucositis and transaminitis, not willing for further chemo, shifted to afatinib. And then another PET was done in which there was only that non-FDG lesion, no lesion elsewhere. She underwent a lobectomy and a lymph node dissection. Final stage was YP, T1B, N0, G2 inner predominant. And in this patient, again, we discussed in our multidisciplinary meeting, and the patient is currently on afatinib because can't afford osimertinib and doing fine at 4 months. Obviously, we don't know whether we or the patients treating oncologists from US did the right thing in getting her resected or not. So what is resectable given this increasing ambit of this thing is that there is no evidence of widespread metastasis by both imaging and tissue sampling. N3 disease has been ruled out by both imaging and endoscopic or surgical sampling. N2 disease is not bulky or multi-station either upfront or after neoadjuvant treatment. And the primary lesion is deemed amenable to R0 resection either upfront or after neoadjuvant treatment. And I'll skip this. We are going to an era of this MRD monitoring and all that. We are again going to skip this. A lot of approvals, everybody knows. I, Kumar, and Ullas were part of this biomarker testing, which has just come out in JTU. And as of now, only PDL1 and EGFR is listed for non-metastatic resectable disease. But before we stop, this is something which has nothing to do with EGFRs. So this was a paper about the carbon costs of in-person versus virtual medical conferences. Just to give you a perspective, so this is the total carbon emissions. And this is 7 digits. So 3.0 million, fully virtual, 18,000. This is a difference of 170-fold. And so this was something for all of us to think, can we move to the hybrid mode as default for the sake of the planet, for ourselves, for our children and future generations, the generation alpha, beta, whoever. Remember, all of this comes from long distance travels from people like me who have no contributions. So climate change is our greatest threat of our time, and this is what we should be doing.